Today we're going to talk about anxiety. In particular, what we're going to do is start with a case that's sort of like a combination of many of the clients I've seen. Miriam walks into your office shaking. She says, "I'm always so panicky. And these attacks happen all the time and anywhere." Confused about what's happening, you ask a series of open questions, so you might think about what you'd ask. In response, she admitted that she worries all the time and about almost anything. She says she often feels shaky, sometimes feels like her heart is pounding in her ear. She couldn't easily attribute her fears to any specific thing, but in her words, anything and everything. So what I'd like you to be thinking about, as we're talking today, is what information would you want to gather to help you make a decision about diagnoses. She's sort of specific, but she's also fairly vague and doesn't really tell you some of the information you want. And think about, as you're looking through your book, what diagnoses would you want to consider? What would you want to exclude? And why? So one that you might consider is generalized anxiety disorder, and I believe you can find it on page 113 of your book. Generalized anxiety disorder has 6 different criteria: excessive anxiety and worry more days than not, at least 6 months, about a number of events or activities. So it's not just occasional worry, and it's not just for a short period of time as you're, during finals week, but it's more excessive and unusual worry, and that the person finds it very difficult to control that worry. In addition, at least 3 of the following kinds of cognitive or physical symptoms are included. Again, more days than not, for at least 6 weeks or 6 months. So restlessness or feeling keyed up or on edge, being easily fatigued, difficulty concentrating or your mind going blank, irritability, muscle tension, sleep disturbance. So, most of us feel some of this sometimes, but we're talking about much more excessive. Clinically significant distress or impairment. So think about what kinds of things this might cause. It might cause problems in school, difficulty studying, for example, as a result of anxiety, or difficulty completing assignments. Might cause problems at work or problems in relationships, because you're having a difficult time relating to people because of this anxiety. Now, you want to make sure it's not due to any substance or medical condition. Many kinds of medicines can have some anxiety producing effects. Some kinds of illnesses can do so. I always assess for caffeine. I've had a couple of clients who tell me that they're drinking, 12, 15 cups of coffee a day. That's, I think that's at least part of why they're anxious. And not better explained by another mental disorder, including some of the ones from this unit. Generalized anxiety disorder affects about 4% of the population, more women than men, almost twice as many women. Often sort of occurs gradually and early adulthood, very prevalent among the elderly, and tends to run in families. We can think about this anxiety as resulting both from a psychological vulnerability and a biological vulnerability, life stressors, perhaps associated with false alarms that cause you to feel more stressed. When most of us are stressed, we experience a lot of muscle tension and vigilance, begin worrying. That causes us to think more, have difficulty solving problems, and also avoid things associated with those thoughts and try and restrict the way that we respond. So there are a number of different treatments for generalized anxiety disorder, or what sometimes is referred to as GAD. The benzodiazepines, including Valium and Xanax, are typical treatments. Generally, these cause an increase in GABA, which is one kind of neurotransmitter. Clearly, they help, but only as long as they're taken. And there are a couple of problems with them, including, that they have a potential for addiction, high potential for overdose. So one of the things you'd want to be assessing for is suicidality. There can be side effects including memory loss and depression. Another kind of treatment is CBT, or cognitive behavioral therapy. And we'll talk a little bit more about that in just a minute. Often what we want to do is some sort of combined treatment, acutely or very briefly do some treatment with benzodiazepines, and as we're doing cognitive behavioral therapy, in order to create some sort of long-term outcomes, positive outcomes. In terms of cognitive therapy, remember there's this relationship between thought, feelings, and behavior. The thoughts cause feelings, the feelings cause behavior, the behaviors reinforce the thoughts. So what we want to do is help people examine the evidence for their thoughts, test them, and decatastrophize. Is it really terrible if this happens? So in terms of schemas, often people with GAD overestimate the dangerousness of situations and doubt their ability to be able to cope. Their typical thoughts are, I forgot to lock the window. I'll certainly be robbed. Or, if my boyfriend breaks up with me, I'll fall apart. Notice the extremeness of these ways of thinking, probably the inaccuracy of those thoughts. Often, as we're doing treatment, we're going to do some psychoeducation about the relationship between worry and sleep and other physical symptoms. It's very difficult to fall asleep when you're worrying, and so one of the ways that, one of the things that I often ask about with people with anxiety is what's happening with your sleep. They may also have a lot of somatic symptoms, and we'll talk more about that in chapter 6. One somatic kind of response is help them to find ways to relax their muscles before bedtime. So sometimes tensing and releasing. And you can, as part of progressive muscle relaxation. Another kind of explanation or thing that we might wonder about in terms of Miriam Trest is whether she has panic disorder. So what we would want to be doing is thinking about how long are these attacks? She doesn't really give us any indication. Is it for hours at a time, or is it for a relatively brief period? So panic is associated with recurrent, unexpected panic, brief, abrupt surge, intense fear, intense discomfort, reaching a peak within minutes. And at least 4 or more symptoms occur from this group here. So pounding heart, accelerated heart rate, sweating, trembling, sensations of shortness of breath, feelings of choking, chest pain, nausea, feeling dizzy, etc., chills. I had one client with panic who went to the emergency room 3 times in the course of 1 week, believing that she had a heart attack. This was a woman like Miriam who was in her 20s, so probably not having a heart attack. The emergency room, of course, trying to, they want to rule out unusual heart attacks, and so they did do an EKG, eventually referring her to me. Panic is so scary that it's often followed by a period of concern or worry about additional panic attacks and their consequences. And often there's some significant maladaptive changes in behavior related to the attacks, including people avoiding places where they have had attack. Again, you want to make sure that there's no substance that might explain what's happening, that there's no illness, that is causing the symptoms. For example, hypothyroidism can cause some symptoms similar to this. Mitral valve prolapse can also do that. And that it's not better explained by another mental disorder. So when I'm listening to someone with a lot of symptoms of anxiety, part of what I need to be doing is saying, GAD, panic. And actually, I may also ask, is this PTSD, which is what we'll talk about in our next video. Here is one woman saying, or her description of that experience. She says, since that first attack, I've had 5 or 6 similar attacks. They're always extremely frightening, but now that I understand what's happening and know that I'll get over it and won't die or something, it's not quite as bad. So you hear some of the results of psychoeducation. Having the attacks can be very embarrassing, and I worry that sometimes I'm really going to make a fool out of myself somewhere. Fortunately, most times people just think I'm getting sick and are very sympathetic. I posted a video on D2L describing of a news anchor who had a panic attack on air. And you can actually see the panic attack and hear his description of what it's like. This figure is one that was taken in the course of just regular research, where they were monitoring heart rate, and you notice the real surge in heart rate very quickly, and over the course of 4 minutes it both peaks and begins to drop. Heart rate begins to drop. As I said, often panic and agoraphobia tend to overlap, so that people with panic often have some agoraphobia, refuse to go out in the world or in places where they're afraid that they may have another attack. So how is it induced, or why do we think that there's some sort of biological piece to it? It's induced by sodium lactate or low carbon dioxide levels, tends to be heritable, and there are also changes in the locus coeruleus. As a result, it's often treated with either antidepressants or benzodiazepines. There's a good response to those, but there's a very high relapse rate when those medications are dropped. As I described earlier, the benzodiazepines tend to be addictive, and so one of the things we're going to do is really try to get people off fairly quickly, or treat with an antidepressant instead. From a psychoed point of view, or from a cognitive behavioral point of view, we're going to be aware of the maladaptive schemas. So these normal kinds of bodily sensations that many of us have seem to be over responded to, and responded with some really maladaptive thoughts. My heart's beating, quickly. Oh no, I'm about to have a panic attack. So we're going to educate about the typical symptoms of panic and the relationship between physical symptoms, thoughts, and behavior. We're going to try and correct breathing and muscle relaxation during a panic attack. So breathing in and breathing out. So the next time you're feeling anxious, pay attention to your thoughts. How are you responding? Are you thinking in ways that increase or decrease your distress? Is your thinking helpful or not? And maybe pay attention to your breath here and see what you can do here. Go back and look at the Miriam case and think about what evidence you would want to help you distinguish between GAD and panic, and take care.